Yes. Oops, let me mute. Sorry. Hmm?
Yeah, I was glad to see Charlie stuff. Did you see the numbers? Yeah, man, just like very detailed. Okay, we got the go ahead from Sam. So back in open session, I'd like to entertain a motion to approve item 3D, the proposed fiscal year 2025 executive incentive plan for the Cook County Health Chief Executive Officer.
So moved.
Thank you.
Second.
Thank you. The motion has been made and seconded. Is there any further discussion on the motion? Okay, hearing none, then, all in favor? Aye. All opposed? Okay, the ayes have it. That motion carries. Move down to item 4 on, action items. The first one is 4A, minutes of the Human Resources Committee special meeting that took place on March 6th, 2025. These minutes were approved by the board at the March meeting, but are being presented for this committee's review and discussion if that's necessary. Are there any corrections that need to be made to the minutes? No? Okay. I'd like to entertain a motion to accept item 4A, the March 6th special committee meeting minutes.
So moved.
Thank you.
Second.
Thank you. The motion has been made and seconded. Is there any further discussion on that motion? Okay, hearing none, then all in favor, say aye.
Aye.
Aye. Any opposed? No, ayes have it, the motion carries. Okay, now we're gonna hear from, our Chief Human Resources Officer, Wynn Buren, who will provide his report.
All right, good morning, everyone. Wynn Buren, Chief Human Resource Officer. I will go ahead and get started. Okay, so CCH for Q1 has a 26% vacancy rate for the organization. Vacant positions, there are 1,917 vacancies within the health system. Of those, 147 are grant and ARPA, 5 are special purpose, per diem, or post-grad, and the remaining 1,765 are general vacancies. The labor conversion initiative added 224 positions, which caused the vacancy rate to increase. Of the 1,765 general vacancies, 74% of those are in the recruitment process. 181 of those are interviewing, 270 have a decision to hire, and 210 are in year-to-date offer positions. I'm sorry, are in offer positions. I want to clarify something that we previously shared. We had reported at the end of March that we had 1,414 general vacancies, but the actual number is 1,842. That lower number was due to a glitch that we found in Tableau, which is being investigated by our business intelligence team. So we will make sure we have accurate data moving forward. We're always looking for ways to improve how we are hiring. One recent change we're excited about is something we call proactive hiring for vacant positions. The goal is simple: to keep things running smoothly and avoid disruptions when someone leaves. So now, instead of waiting for a position to be filled, or now instead of waiting until a position is officially vacant, departments can begin the hiring process as soon as they know someone is planning to leave. Next slide.
I'm sorry, how did the error occur?
It was an error in our Tableau system, so we didn't have the right data in there, so we're double checking to make sure that going forward the information will be correct.
One question off the error. What actions did or did take as a result of the error?
We are looking to understand why it happened, but now we're updating things manually.
So how long has the error been there?
I found out about it in the last month, so between the last report and this one, we found it for our vacancy.
So that glitch wasn't there in the previous report?
I believe it was. That's the point I'm making.
Yeah. That's why we're updating the numbers now, so we will make sure going forward that we don't have those errors. Okay. So from a manual standpoint, we have something in BI that wasn't working correctly, so we need to make sure that going forward it is.
But we're not sure how long that glitch had been running before you identified it.
I'm not, but I can find that out.
Okay.
So I guess we're trying to understand whether previous data presented to us was accurate.
Right.
I don't think it was.
Yeah.
I can verify that
Yeah.
for you. I believe it was for this quarter when we reported based off that time period.
Yeah.
But now it's correct.
Okay.
So I think that, I think the staff has to do the assessment before we speculate any further, but,
Fair enough.
so yeah, we'll be interested in what comes from that assessment.
Okay.
Thank you.
All right. Next slide, please. Recruitment and retention continue to be key priorities for us. At a high level, our HR metrics indicate positive movement. with an increase in new hires and a decrease in employee separation. The result is a net gain, which demonstrates that we're successfully retaining talent. We'll take a closer look at these hiring metrics in the next slide. And we continue to work on time to fill to drive efforts towards processing optimization and technology solutions. We've seen positive outcomes on time to fill. When we look at both internal and external hires combined, our overall time to fill is 111 days.
And the goal is 91 or 90?
The goal is to get down below 100 into the low 90s. For nursing, time to fill was 86. Our external time to fill was 109. Next slide, please. Okay, so this is a report on our current state of hiring and separation. We've made 797 offers. Of the 797 offers, there have been 590 accepted offers. Of those 590, we've filled 528 positions. This includes 134 internal candidates with promotions and transfers, and 394 external candidates that have joined Cook County. Our separations continue to trend down. From an offer acceptance rate, we're at 77%. And from a declination rate, we've had 178 declinations. Retirements continue to trend down. We had 90 in 2024, 80 in 2025, so it's an 11% decrease from 2024. Resignations continue to fall, so we had 87 in 2024 and 80 in 2025. Discharges decreased as well. We're up slightly to 25 in 2024, but decreased to 14 in 2025, so a 44% drop. Net new hires saw a large jump from 100 in 2024 to 220 in 2025. So we're trending positive there, about a 120% increase.
Do you have numbers on anticipated resignations or anticipated leave for this year, so that you can also look at what may be required in terms of potential attrition for the coming year?
I don't have those on me, but I can get them.
Okay.
Question for you. With the retirements, what would you attribute the decrease to?
And I'm sorry, I don't have that information on me right now.
Okay. The reason why I'm asking the question is because we've been looking at this for a while prior to your coming.
Okay.
And so what we're trying to do is to figure out if we are actually giving people a reason to want to remain, because, you know, we all came through COVID and there was a lot taking place. So in order for us to be able to try to meet the need within this category, we've got to slow down the leaving people who have a choice. And hopefully we have some HR things that are helping them to want to stay versus, hey, I'm out of here. And then we're trying to get the people in so that we can actually fill the need that we currently have, which will allow us to reduce our dependency on the outside forces.
And Director Robinson, I understand. You know, one of the things I do understand that we've had an increase, we've had pretty good engagement numbers, which I think has shown that from an engagement standpoint, we are providing an organization that people want to be a part of.
Okay,
But I understand what you're asking.
Okay.
I'll have more detail.
Maybe you misunderstand my perspective. It's not saying we're not doing a good job. The question is, are we doing enough of a good job?
Right.
So it's not a critique. It's just simply trying to say, how can we improve? It's a continuous improvement process. It's not a critique at all.
Yeah, so I think employee engagement, we've seen a nice trajectory so far from 22 to 24, and we're continuing to deploy tactics to engage our teams. We're looking at other, types of programs that we might be able to launch that would further improve. But I think, the trajectory, it is what it is, and I think it speaks for itself, right? I mean, there are fewer people leaving, to your point, right? And I think that's I think the most apparent thing that I could tie it to is the trend in engagement.
I think we had also discussed maybe some innovative ways to encourage those that are kind of nearing when they might retire to be able to stay, like offering a slightly decreased percentage of their schedule so that they might have the longer weekend times, or to allow, we're going to take 2 weeks off during this, so that they could start to have that work-life
little bit
balance
more
that
of
we
a- yeah.
generally attribute to being able to retire and then being able to do more things. A lot of programs are looking at, say, we know you're at retirement age, but you want to keep your feet in. So what are some ways that we can try to manage their schedule to allow them to have that work-life balance? So I know we had discussed that as
Right.
well, too.
And if we're not measuring it, we're not sure what's working and what's not working. Because if it's working, maybe there's some other areas and more things we
Do
can
more
do
of
in
it,
that
yeah.
category.
Yeah, sure.
Or a survey on, hey, we know you're within so-and-so years of potentially being able to retire, or age-wise but what might be some things that would keep you here or allow you, and then addressing and then looking at that in a really more engaged process with those that might be considering potential retirement in the next few years.
I think
Some
that's fair feedback.
potential ideas, yes.
No, I think that's great feedback. Okay, next slide, please. So here's a snapshot of our nursing recruitment efforts. Year to date, our recruitment team has successfully filled 174 nursing positions, broken down by 65 non-RN, 9 nurse leaders, and 100 direct care nurses. This includes 47 internal candidates and 127 external candidates joining Cook County. And we'll go into more detail in the next slide. For direct care nurses, we've made 180 offers. Of the 180 offers, 120 were accepted. There have been 100 filled direct care nurses, includes 33 internal candidates through promotions and transfers, and 67 external candidates. As previously stated, our hiring metrics show a decrease in hires due to agency conversion. The agency conversion initiative, we've hired 6 recruitment and selection analyst positions. We're collaborating with the Employment Plan Office to amend the employment plan and permanently include accelerated nurse hiring, which I will speak about a little bit later.
So that lag that you're seeing from those accepting the offers versus actually now actively employed, are those credentialing background, are those external factors that's slowing that move from
Part of the
acceptance
challenge
to
we had is
initiation?
that we were focused on agency hiring, so a lot of our resources were being used elsewhere.
Okay,
So we've moved past some of that now, and we've hired 6 new recruitment and selection analysts, so we should be able to see that lag decrease.
great.
On this particular slide, information that would be helpful is to say how long was the positions posted internally? And that's simply to make sure that when someone raises the question and say that we're hiring people from the outside, that we did not give those internally an opportunity. But if we have the numbers printed, then we don't have the question being asked.
Okay, next slide, please. So I want to talk a little bit about our hiring fair from April 30th. I'm excited to share the results of our recent nurse hiring fair for med, surgical, and emergency medicine and stroke. This event is a key step in our ongoing efforts to fill nursing positions efficiently and effectively. The fair was well attended. We had 136 nurse candidates come out to explore opportunities with us. We were pleased with the level of interest and engagement. We made 31 offers, 29 external, and 2 internal candidates. So we hired 31 folks. We also were able to create a consolidated rank list that includes 77 people. So we'll have 77 folks that we'll be able to reach out to should we have other openings.
Great.
Is it, the 31 is it a diverse strata of experience?
It was for these specific roles, right? So emergency medicine and then med nursing.
Yeah, I get that, but I'm asking, are these experienced people, or are they people coming right out of school?
I think we'd have to probably take a look.
Oh,
Yeah, I'd have
you don't need to do that, I was just curious.
Resume file.
Yeah, it's a hell of a percentage, 100%. It's great.
So the 100% looks good. If you look at the actual number, that's only 22.3%. So of the 136.
So we only had a limited amount of PIDs positions that we could actually fill. So every position that we had that we could fill for this particular job fair is going to be filled.
Right.
Oh,
So we have start dates throughout the summer for these folks.
Okay.
So we were limited in what we could actually do.
So they created the rank list so that with the next position positions open,
Yeah,
you already
So
have
we've now got-
77.
Now we have a bit of a
On the
pool that we
pipeline.
can go to in the future.
Okay, that was gonna be my next question.
There you go.
Excellent. Okay, cool.
I think one of the opportunities is how do we have a bigger bucket of free and clear positions? So when we do have this at 77 is we're putting in more positions, right? We have more positions available to fill.
Correct.
And
There's a
ways
certain
to keep
process we
those,
have to follow, but now that we have this group, we can dig into it.
and ways to keep those 77 engaged so that they don't,
Yeah.
you don't have that
That's a
drop
big
off.
deal. That's a big
Wow.
deal, right?
That is true. We want to make sure that we reach out to them.
And again, I'm sorry, what was the experience level of the 77 in general?
That I don't have on me right
Okay.
now.
Because before, I think the deficit was in between the 5 and 11 year. As far as experienced nurse, that's where we were seeing the problem with trying to fill in that gap. Okay.
Yeah.
Current state of agency use, I think some of you have seen this slide before, or something similar to it. So we continue to focus on converting agency workers. We've made 335 offers, 231 were accepted, so we're at an acceptance rate of 69%. We've already filled 181 of those positions year to date through 5/9. And then we have start dates for the other folks throughout the month of May and going into June as well.
Do we have a mechanism in place so that this data gets disseminated to our general nursing staff so that they're aware that we're making those active efforts at decreasing the staff
So
to agency ratio?
These agency workers are not, the nursing staff.
Are the nursing staff made aware, or do we have a follow-up period to discuss to make sure that nursing staff that are employed know that we're actively working to decrease the agency rates?
Yes, and I know that we talked about this at our leadership meeting.
Right. I
on
see
a
Dr.
regular basis.
Peters like about to jump up too, sorry. We just want to make sure that our ongoing staff here know of these active engagements to decrease that staff to agency ratio.
Yes, actually, this is part of our monthly standing meeting, and also when, Nurses Week, all the nurses we did around, we shared the goal of decreasing our agency. And also a number of us met personally this agency nurses. I would say close to 70 of them are ready to join. And to our staffing, and I know, Mindy is working on a process, so I think we will see lots of movement from conversion, plus the nurses are aware of it, including, NNOC and others to this program, yeah.
Okay. I want to make sure that the ongoing staff are hearing things, because if the tree falls in the forest, we want to make sure everybody knows.
And they are also meeting this agency nurses and recruiting them for us, so I think it's all kind of going in the right direction.
It is.
Right.
And as I kind of wrap up some of this report, one of the things I wanted to talk about is the accelerated hiring process. So we've worked with, the OIG and the Employment Plan Office, and we're going to be rolling that out, in the coming weeks. So we will be able to speed up our time to recruit. There's a couple very specific processes we'll have. So for instance, posting for 14 days for certain positions, we'll go down to 5. We'll be able to, make an adjustment to the interview process. There's a set of things I have right here that we would have to do without getting into detail, but that's going to help us, in recruitment across the board, but especially in nursing.
Thank you.
That concludes, the report. Are there any other questions?
No, just, I appreciate the presentation of the information. I like how you, graphed it. The illustrations are good. Thank you.
Keep up the good work.
Yep. Okay, we're going to move to item 6, where we will now review a number of reports relating to strategic planning that were initially planned to be presented at the last board meeting, which was unexpectedly canceled. So these will be reviewed by this committee for the purpose of efficiency, so the timeline and schedule of the activities for the strategic plan is not delayed. So, let's see. Update on strategic plan review delegated to Human Resources Committee. That was done on May 8th from the board meeting. So we'll go into an introduction that'll be led by Andrea Gibson.
Thank you.
Thank you.
Andrea Gibson, Chief Strategy Officer. Today we're going to be hearing from three areas, nursing, HIS, and behavioral health. All three of these areas have worked extensively with their teams to develop a detailed strategic plan that aligns with the overarching strategic plan. And so we thought we would hear from them to talk through what the process has been for them and what they've accomplished and what we have to look forward to as well. So we'll start with Bina, and she can come up, and I'll take a back seat here. And then I think after that it's Angela, is that right? And then Dr. Nutter. Okay.
Thank you, Andrea. So I'd like to share the high level on nursing strategic plan for the next 3 to 4 years. And I shared this nursing mission with the team in the past. That continues to be our mission, to build a high quality, patient-centered and integrated health system, maximizing the resources, ensure the greatest care to our community. Nursing mission is something we drafted in the last couple of years through our shared governance structure. Our vision is to be a beacon of nursing excellence, delivering compassionate, culturally competent and evidence-based care to uphold the patient safety and foster the professional growth and drive innovations to achieve optimal health outcome for our diverse community. So that is what, pulled by the nursing team and all of things. So let's move to the next slide. So from a strategic planning and priority perspective, I know all of you have seen this slide. This is our continuous journey on nursing priorities to zero harm initiatives to improve the safety, also efficient and effective care delivery model, workforce planning, and patient experience growth, innovation, and the optimization and systemization, which aligns with the CCH overall strategic plan. So next slide, I'd like to highlight our accomplishments, what we are. This is again all of it. This was presented multiple times to the board. So to highlight, it is so proud to say that the nurse-sensitive quality indicators across the system have improved more than 87%. And if you look at each category line, right, hospital acute pressure injury is something we take pride every day regarding a 98% improvement. So to overall, each quality process improvement also is directly affecting our patients' safety score as well as the length of stay and other factors. So each incident has a cost to the health system. So overall, if you quantify these initiatives in the process improvement and clinical outcomes, has a cost avoidance of more than $25 million based on the incidence rate from 2019. So we are really moving in the right direction. Next slide, please. So that's acute care. Acute care consists of closure and crowded, and also there's a lot of work is happening in the other nursing areas, including ambulatory. Lots of focus on improving access that include implementing a streamlined our message management process where we decrease our long wait time for the message by 53%. And also we have implemented number of nurse-driven protocols to manage the chronic care visits by RNs, not APRNs, RN, which is also supported by Medicaid and Medicare programs. And also central nursing triage process. Central nursing triage process not only improve the access, but also help to decrease some of the emergency room visits. Moving on to public health nursing, the highlights. During the COVID, I think the whole team invented the nurse video visit program to make sure that the patients are taking the medication. We started this program with the TV program, and now we enhanced it, and that actually now is part of the overall care delivery model. Also, we integrated public health and community health workers to the public health program of nursing to really enhance and provide resources to the families and the communities we serve. And we used to do the hearing test for schools, now we restarted that program after the COVID, and the public health nurses are doing more than 4,000, screening, partnering with our Chicago public health schools. We also expanding the program for nursing, public health nursing, where we are now getting, bachelor's and master's nursing students doing their clinicals, to really introducing the public health nursing part of the baseline, basis of nursing care delivery structure. And also they continue to provide flu and COVID vaccines. Other highlights also, part of the public health nursing program, the group brought up all the resources available to maternal child health to the public and developed our website. So anyone can go to the website and really understand the resources, and this is one area that we are really working to improve the health and well-being of the maternal child population. Next slide, please. This also to really highlight what's happening at the correctional health system. We have a strong nursing leadership team to really bringing the correctional health nursing program to make sure that the optimal care is delivered at that system. So the three main focus areas are medication compliance, that is a requirement, part of the standard. And also, whenever a detainee or a patient requests for a health visit, a nurse must see that patient within 24 hours. So that is one of the quality metrics. As you can see, we continue to exceed that expectation. The third focus area is on really contraband count. At the correctional health system, we do everything to, stop or avoid the contraband within the system. And this is actually a huge process improvement done collaboratively with the leaders, operational and the medical leaders, to make sure that we meet and exceed the expectation. As you see, it's about, we are close to 100%. Next slide, please. So just want to highlight, one thing we take so proud about our nursing turnover rate compared to the national average. So we still continue to be way below the national average, and the 2024 data just came last week, which I will update. Overall, the national turnover is going down, but 18.8 now. However, we are below 10%, so which take us to be one of the top performers in the country. Next slide, please. This one slide, I know we mentioned a little bit about the HR slide about the nurse and employee engagement score, very specific to nursing. I just want to highlight to say that there are two key indicators on employee engagement, and part of the Prasini, they have a three-tier system. The tier 1, tier 2, tier 3. Tier 1 is actually the true testament of the collaboration and engagement. And if you can see the data from 2022 to 2024, 22 we have 0 nursing units were at the tier 1 category. So lots of work on shared governance. Now it's 27% that is, into the tier 1. That truly tells us about all the work we are doing on employee engagement. In this particular table, we want to see less percentage in the tier 3 and more on tier 1. And also the tier 2, which is, mid-level performance also increased. So that is really a huge effort on shared governance structure and also participation of our frontline staff to making clinical practice decisions. And also, if you look at the leader engagement, this also truly tells us how our leaders are engaged with our frontline staff on making clinical decisions. So leader engagement score was to 38% in our last survey, and this survey increased 67%. And when you look at the overall national improvement, Prasini called this as a significant improvement in the employee engagement. So this is huge for us. And again, with this, I really wanted to get the kudos to the frontline managers to really bringing that true, to the challenges and opportunities to our frontline nursing staff and working with them. Next slide, please.
Question for you. With this type of improvement, how does this impact our score? Or, I'm sorry, the scores that the hospital is judged by?
Employee engagement is not one of the factors contributing to the patient, the employee to leapfrog. However, right, engaged employees create the better outcome. So all the things we talked about, the clinical outcome, patient experience has a correlation to engaged employment. Dr. McIdy's like to add anything.
I was gonna say the exact same thing. It's foundational, right? The more engaged
Right.
your team is, right, the better the outcomes are gonna be, the better patient experience will be, right? So, and those are all
Although there's
measured.
not a specific indicator to
No, it kind of
track
feeds
that.
into the
Yeah.
other stuff.
And I know we'll talk about the Pathway to Excellence program, and this is going to be one of the strong indicators for whether we qualify to put an application or not. So more to come on that.
While you're in this section, are the improvements that have been made as, in the correctional health, do you actually calculate the cost avoidance?
No,
Relate-
that's,
Yeah, because we know that now there's a really big focus on the lack of appropriate care for patients that are in correctional health centers. It'd be very interesting and compelling to see what the cost avoidance we have in providing that nursing care appointment after 24 hours once someone requests it, to what may have unfortunately been costs that we would have spent if we had not done that, to see that on that clinical excellence note. Other facilities, and sadly, we frequently see those media-wise in a negative way too, when we don't provide that correctional health service. It'd be interesting to be able to see that in the cost avoidance calculation that you have there.
no, thank you, excellent point. I think that gives us an opportunity to really look at it, what you
Right.
said. Great point.
Here's another question, because I was looking at the space for a long time with correctional. When they're discharged, do we know if they tend to come here?
They do, there are programs, there is a program between our county care and the correctional health. The county care nurse coordinators actually introduce the county care to correctional health patients that they can join. And there was a poster presentation from county care about that relationship. So we are starting, I think we do have some opportunity to get to 100%, but many of them are aware that they can get the care within our system.
Right, I think we have a perfect customer that we're letting walk out the door if we don't do it. There's great opportunity from a multitude of standpoints to be able to provide to the community, to get the revenue by getting them signed up for county care, and then to reduce the cost because they're in constant care. There's a lot here, because it's almost like if they're familiar with us, then they can trust us. If we're doing a great job, which it seems like we are, then we shouldn't lose that opportunity.
Excellent.
Specifically given that they're in correctional services, which sadly is a stigmatized location for healthcare, and they may have had traumatizing experiences not getting healthcare when they were in correction systems, now being listened to and their needs being answered, you have an excellent opportunity to directly engage them now in the care post-release.
That's an excellent point. I think we can bring in that project to this group and look at the numbers too, because that's a priority for our county care to enhance their membership too.
Right.
Excellent point. Let's move on to workforce. Next slide, please. In this slide, again, there's a lot of information here, but I just wanted to highlight that, a lot of focus is happening within the nursing, of course, in collaboration with our HR partners to build the programs, right, from a retention perspective. So we have nurse residency program, we have nurse extension program. We are also one of the sites within the city of Chicago, the only site accredited for APPs from ANCC. We have nursing preceptor program, journal club, the grand rounds. Nursing School Summit is really a highlight, because with this, our 2 nursing school summit for the last 2 years, we increased our nursing student placement by 542%. That means we are really bringing those students, and that externship program should really help us to recruit. So I think there's a lot of growth in that area for us to have a strong collaboration with all these academic and educational facilities. We have nursing certification program. Now we established a structure and process to track them. 22% of our nurses are certified, and this is our goal is to get to 30 to 40%. Still, so we entertain international students through collaboration through UIC, and actually I had an opportunity to listen to their strategic plan. They highlighted their experience with Cook County upcoming, so we continue to this national annual engagement on international students. And also, nursing, there's a lot of best practice presentation we are doing across locally, nationally, to talk about all this improvement. So there's a lot of supporting our nurses to go out and present. It's not only, elevate the care that we provide and communicate, but also to outside. So next slide, please.
I know you've worked on, the high school entry activities as well, too. I know we've discussed this. It'll be good to be able to see those that really creating that pipeline and engaging as well.
And yeah, this also going, taking lots of time, but quickly, nursing innovation and evidence-based practice, we established the innovation center. We hosted our first nursing innovation and research conference here, participated by more than 100 people across the city of Chicago and Illinois. And also we had our first correctional health conference, Midwestern, too, attracting, and sharing the best practices. Next slide, please. Just want to highlight the pathway to excellence. We had the ANCC has two designations for hospital for nursing excellence. One is magnet, one is pathway to excellence. And as the nursing and each entity leaders in collaboration with the frontline decided to go with the pathway to excellence, and I'm so excited that because pathway to excellence really focused on employees' work environment and engagement. So these are the 3 steps that's part of the high level. Next slide, please. This is a busy slide. All of you have this in your package, but truly this tells us the story about how we are integrating a professional shared governance structure to bring the voice of nurses across the system. So we have councils at the entity level and the system level. I co-chair the system council with one of the staff nurses to really make the, to have this process go through. Through this process, we have now about 250 frontline nurses are engaged. And this is actually probably one of the main secret sauce for to improve the engagement and the results that we saw. So this is our structure. Next slide, please. This is again high level on our pathway to excellence journey map, and our goal is to submit the application for the intent in the next 3 months, and hopefully the goal is to get this at least one entity accomplish the pathway to excellence designation by 2026 fall. So the details are here. So a lot of work is behind, but we are going to that journey. Next slide, please. So let me just highlight where we are with the current state. This is one of our area of focus is to high nursing vacancy rate. We are, still around 37%. This is just nursing alone, and this is, we talked about strategies at the previous presentation on how we are achieving it there. Next slide, please. This is also a demographic slide for information only. We want to make sure that we have actually bringing the diversity to our workforce, and that is representing our patients and who we serve. So this gives an idea of, what is the nursing demographics are. Next slide, please. High level SWOT analysis, so it's also part of the package. If you really look at it, the strength, the SWOT analysis and the nursing strategic plan was developed, by frontline nurses, the nurse leaders. We had our first meeting to talk about how do we build our future strategic plan. So that group came up with the SWOT analysis, and these are some of the strength opportunities and things we need to look at it. So opportunities, again, creating a flexible workforce, part-time position, as well as to really looking at the care delivery model, which is going to change eventually from hospital to homes or communities. So this is the highlights on our weaknesses as well as the threat. Global nursing shortages still continue to be on the list. Next slide, please. I also want to highlight what is happening in nursing in the market scan. I think what we are faced today is not alone for Cook County. So people are looking at healthcare workforce shortage and looking at the aging workforce. Average age for a nurse nationally is now 49 years. And so that is a concern for us as well. So we are around, ours is 51 years. Flexible workforce, that's something we talked about. Can we have part-time positions within the system? And workflow changes, and also there is also identified shortage of nursing assistant shortage is also international issue, and then also growing demand to increase volume and activity. And virtual care will be a part of this whole. Everyone is getting into virtual care. Next slide, please. Want to highlight the strategic pillars, what are the priorities, the details are in this slide. So under the quality safety pillars, we want to focus on pathway to excellence, achieving this designation. So it's a, designation is one thing, but I think the structure that we are, committed to build within is really going to improve the practice of nursing across Cook County, employee engagement, as well as enhance the practice environment. That is where we will be addressing the burnout and things like that. So this is very high level, and I know we have few other presentations coming. So it really, I think, is, running an operation of nursing excellence through benchmark data and also related qualities associated with it. Next one, please. So this is our health equity pillars. When nursing, we started talk about improving care, that is directly correlation to health equity philosophy about the right care of patients, right time, regardless of their background. So that's how we bring the quality to this discussion. We also wanted to bring the education and on competencies, cultural competencies, part of it. The other big area we wanted to talk about improve the patient communication and accessibility. The work we are doing at the ambulatory space to improve the chronic care management visits as well as the APRN practice to do the improve the access should directly correlate to the care access and equity. Next slide, please. Workforce is, again, this is a huge area we will be focusing on the coming years. I highlighted some of the accomplishments. We continue to focus on the pipeline program and decrease the vacancy and also increase the hiring velocity and establish a flexible technology supported care delivery model. So that's going to be the focus. Also, we'll focus on creating a wellness program, workplace wellness, and workplace bullying also going to be part of it, really enhancing the engagement. We have seen a significant improvement, but we still have to really look at the wellness program, integrating that to part of our daily practice. Other area we are going to focusing on staff recognition. We established the number of recognition programs. However, I think it's very important that we really bring that to the next level. And also, we wanted to look at some of the nursing training programs. So I know we had a nursing school once upon a time. So that is, I know, one of the priority with the system to see can we have a collaborative partnership to create programs within our system for nursing assistants or perhaps for RNs too. So we need to explore all the options. Next slide, please. This is where transformation, this is where we want to expand our nursing innovation as well as the research evidence-based practice program to optimize the care delivery to ensure that the quality delivery programs are in place, and that is part of our daily, everyday practice. Hardware, the high reliability principles, part of the program. And also foster, we also culture of innovations. I know the nurses are now part of the national programs where, participating Johnson & Johnson innovation programs, as well as the Nurse Hackathon. We were the first top winners globally. So it's a lot of action. Now we really, engaging frontline nurses to create the innovative care delivery model to be part of this. Next slide, please. That's the last slide. And the physical resilience, again, once we kind of talk about, decreasing the vacancies, looking at the care delivery model. And also we have benchmark data for nursing workforce hours for patient care and deliveries. Want to make sure we stay below the national, mean, which we are. So I think really communicating that with our nurses. And one other big project will be part of this is to looking at the time that clinicians spending documentation. We have huge opportunity to decrease our documentation burden by 40%. So this will be going to be a priority to work with our EMR and others to really look at the streamline the documentation process. So you will hear more about that. And also foster a culture of accountability and regulatory compliance, part of it also our priorities. Next slide. Yeah, this, I know I was rushing it to make sure that I get to highlight, but again, the details are in your package. If you have any questions, let me pause. I was rushing a little bit, but let me know.
I don't have any questions. I just want to say that it's obvious that this is a very comprehensive and targeted approach to really strengthen the nursing profession at Cook County Health. So I assume you're working hand in hand with Wynn as you're filling the vacancies, and it seems like there's from where I sit, it seems like there's a good chemistry there. But it's come a long way. I mean, it's really great work you're doing.
Yeah, thank you so much. Yasmin and I talk, I feel like every day.
Yeah. Seems that way.
Thank you all.
Any questions or comments? No?
No, it's a
Thank
very
you. Excellent
bold goal,
presentation.
so keep it up.
Thank you, Bina. We'll go to technology, and we'll have Angela O'Banion take us through that, please.
Good morning.
Good morning.
Good morning.
All right, let me get started here. So first of all, I'm Angela O'Banion, as mentioned. I want to thank you for the board for its confidence and its financial support in allowing us to continue to serve our patients and end users with a material investment over the last several years. I know the time is upon us, and so we will focus our efforts on three major areas in technology. The agenda is before you, and there's a highlighted materials on each of the topics. Next slide, please. So the names listed here is not the entirety of the HIS team, but they are the persons who were primarily contributed to the document and whose areas of focus we are discussing today. Of course, the strategy is about the future, but a quick recap is important to do. And can you go back one more? Sorry. Okay, go ahead. Sorry. Go ahead. One more. I was just ahead of myself. So in our current state, what I really want to focus on is to draw attention to the fact that we serve the entire Cook County Health System, all of our hospital and services and patients within, including the several technologies for the plan, that we do over 1 million transactions daily, from checking people in to discharging to interfacing with numerous external systems, whether it's laboratory providers or customers paying bills through our financial payment systems. The next slide is really about our SWOT. It's, I always just remind people a little bit about what we're talking about, and I'll leave it, as I said, to you to look at the details, but we are going to focus on the items with the directed arrows, which are consistent with our agenda. So we have a lot of demands as we talk about every board meeting, and as you've heard from the colleagues who spoke before me, but there are several areas that we are going to focus on today: leveraging AI, bridging our digital divide, and continuing to build our high maturity and security program. Next slide, and I'll talk about each of these. So one of the things that I really wanted to highlight first is leveraging AI is very, very important. Everyone is talking about artificial intelligence. And what I want to say first about any technology that we use, we have a policy. We are governed by state and local, in addition to national standards as it relates to artificial intelligence in the use of healthcare. So there are approved use cases that go before our Bureau of Technology, and there are a lot of governing policies and codes, even ordinances with the county about what technologies can and cannot be used in county entities of which we are. I just wanted to make that statement. One of the great highlights of the recent work in AI, and again, we have dozens of AI applications, from robotics robotic surgery that learn movement patterns, to allowing users to have meeting minutes that are transcribed with AI, radiology reads, coding assistance, not to mention the 200-plus applications and the associated vendors and all of the AI they are using to develop their own code. So there are many, many cases that we could have used. Since my friends before me, colleagues before me went, we are in the midst of nursing AI selection, which will help in staffing and scheduling, which also speaks to WIN and human resources and tools that his department is using, such as Taleo and LinkedIn, also have AI capabilities that help streamline some of the administrative functions and match candidates. So it's everywhere. But today we'll talk a little bit about provider documentation. You have the statistics before you about how much time the average provider spends in documentation, and you can imagine that we're above average. Patients don't like it when they're providers. You as patients probably aren't thrilled when your doctor turns around and looks at a computer in that 7 minutes that they have with you. And then, of course, the electronic health records have been attributed to provider burnout, and they just don't feel like they're spending enough time with their patients. So next slide, please. So we've launched our Oracle Clinical AI tool, which is meant to do the opposite of all the things that I just talked to you about on the prior page, including improving accuracy and notes, et cetera. Next page, so I'll get a little bit into the pilot. And some quotes from some of the providers that have been using the technology. We've been doing this now for, I guess it's 97 days since I put this together. We were only going to start out with 10 providers, but more and more heard about it, so we had to increase it to 40. And one of the things that you can see is how much volume there is over a 3-month period in the type of work that we do. And there's some quotes that you can see at the bottom. I'll give you a second to take a look at those. So again, this is just phase 1. And on the next page, we talk about what we've seen so far, which is a 35% reduction in how much time providers are saving in documenting. And when we extrapolate that, which is on the next slide, I hope if I have this in order, you're talking about the ability to save 2 years worth of time. And we always talk about you can't buy back time. Well, we're trying to do that with artificial intelligence. These technology tools in physician ambient technology, which basically you're in the doctor's office, you're talking about everything from ballet to one of our 2 baseball teams with your provider, and they're also talking to you about the care. The technology is smart enough to take all of the extra information out and code exactly what it needs to into your patient record. And from there, we take that information and those notes, all of that feeds into various systems, including our coding assistant, which we've had for years. And so you can see how this entire effort balloons. It increases provider satisfaction scores, patient satisfaction scores, et cetera. So we are very, very excited to have this particular type of technology in AI. And again, like I said before, we've had dozens and dozens of AI applications across the board in administrative functions like meeting minutes, and also in remote technology, radiology. There's just a preponderance of it throughout the system, but this is just an example. I'll pause here after the AI section. I know time is of the element.
I do have a question. Oh, go ahead.
Oh, no. And patients were accepting of the AI recording, you know,
Yeah.
sometimes there's the, where's that information going?
Yes.
They felt accepting about
Yes,
utilizing
and they're
that for
very
eye time.
used to
Okay.
it more, as more people are using tech AI, which of course can be defined as chatbots, machine learning. As I said before, in the robotic surgery, it memorizes people's motions and movements and helps that technology become better. But at least 50 plus end user cases now, not including the hundreds of generative AI development that's being used to improve, code development from our application vendors.
Do you have an idea of what the almost 16,000 provider hours saved, is valued at?
Will save. So this is just an extrapolation. So in the prior slide, we were just doing a pilot right now, and we've seen a 35% reduction in the prior slide. If you could, Debbie, we've just seen a 35% reduction in, since we started our pilot. And one more back, I'm sorry, that's the nicer one. So we've seen a 35% reduction in provider hours. And what we want that time to be used for is more, right? More visits, specialty care, especially in some of the areas where they're challenged. We want it to be used for more consults, e-consults with patients that may be at CERMAC and other places. So more time seeing patients face-to-face as opposed to documenting what happened when you saw them face-to-face.
I mean, that's significant.
Huge.
If it's 16,000 hours.
That's a few years, right?
Right.
Back time.
I mean, that's the equivalent of, I'm guessing, like 8 providers.
Yeah.
8 positions that you've saved in time
Yeah.
to re-engineer the work that
Right.
you want them to focus on.
And I think
Yeah.
It's impressive.
the important piece with that time bought back is beyond, how many more people can we see? It's as we start risk stratifying and we identify our sicker patients who maybe
Right.
need a little more attention, they can spend that extra time with those
That's
patients.
why I mentioned things like CERMAC and consults, teleconsults, and telehealth appointments, which are sometimes difficult to fit into a schedule when it's complicated. But if you can get back some of that time and reduce the documentation, you can make that easier.
And that 7-minute, for some who may need more, you have the
Yeah,
opportunity to do that. It also then leads to, billing
Yeah.
can result in, so.
And all of the
Comes back in many
algorithms
ways.
will eventually help you determine how much time you really will need with the patient.
Exactly, because the AI can let you know
Yeah.
that as well, too.
Exactly.
So just make sure that AI that you're using, it captures the natural conversation.
Yes. Natural language processing, ambient conversation, and absolutely. This is our part of our current EMR, which is Oracle, also known as SIR.
So then it should be able to also capture the social determinants that are being spoken.
That's right.
And then someone can act on that before that person leaves the hospital.
Yeah, you can, there are, the next phase is the orders and the care management that happen from that, which can be automatically populated and sent to people's phones, and everything much faster, much more immediate, quicker decision-making.
Social service referrals.
Right.
Yeah.
Don't have to come to the patient room because you just saw it pop up on your phone. There's just so many different usage as the machine learning gets smarter and smarter and is able to target who should get what information. So we could talk about AI all day. So we will go on to the next section of our focus area, just telling you a little bit about some of the other services that we use, which is also augmented by AI, but it's the tele-virtual health objectives that we're working on for the same reasons that I talked about before, productivity, et cetera. All of these tools are designed to ensure that we spend more time with patients and have more targeted healthcare. So on the next slide, we'll talk about, just like I said, a little bit about the definition of artificial intelligence. There's different types of telehealth services, and so it's important to understand broadly what it is that we're talking about. And all of these services are currently in use now, and some have been in use for more than 7 years. Next slide, please. We're very happy that our, physician and nursing community helps us, allows us to service them and comes up with many, many different use cases for us throughout the year. Next slide, we'll talk a little bit more about where it is that we're using some of these things. So we also have one of the things that we're really focused on, you hear Craig talk about, that you hear a constant conversation about, is specialty clinicians and experienced providers being able to use technologies such as visual monitoring, sitters, so that you don't have to necessarily have employees or nurses whose time is valuable, monitoring patients, whether it's, they want something to drink or to eat, or there's something really serious going on. Those are just some examples of some of the, things that we have live right now. And there's a lot of information on these slides, and I'll, as I said, leave it to you to take a look at. These different types of technologies will, of course, benefit the staffing and scheduling, as I said before, needs for BINA and HR. Next slide, please. So there's a lot of literature out there. This is a illustration of a virtual care environment, virtual sitter environment, which is slightly different than virtual nursing on previous slides. But again, the time is short to get through all of it. So the third area that we want to talk about, so the three areas of focus that I said we would talk about in our strategic plan were artificial intelligence and telehealth, and another area is information security, which is really what I wanted to talk about. We all know that there are just many cyber incidents that have happened, you know, and we are constantly monitoring every single day, 24/7, to see what's happening in our systems. I don't have to tell you about all the threat actors and malicious attackers that are out there, but this is just basically to let you know that we have very mature, as you'll see on the last slide, National Institute of Standards and Technology frameworks, along with other frameworks that we're using to ensure that we are mitigating all information security risk and elevating our knowledge of information security across the organization. And this is an area where we have invested, materially increased over the last number of years. So if you go to the next slide.
Question, Angela.
Yes.
With the NIST standards, have you seen a decrease as a result of federal actions of cutting out the different departments with funding?
We have not seen any decrease, and we do have many reports that talk about the impact of every executive order on technology, but we have not seen any decreases in the administration's commitment to cyber threats and information security. And in fact, one of the things that we're doing is we constantly looking for where the executive team is focusing. I know we're all talking about where they're not focusing, but they are focusing in some areas and prioritizing certain types of technologies over others. And so we're looking to leverage that when we find it, but we have not found any decreases. And we do extensive work with our Gartner partners who we use as our advisory services and our other partners across the system for reports that we get every week. We have not seen any decreases in priority. Next, please. So I just want to talk a little bit about the fact that we protect the edge of our solutions, of our system, as you can see, whether it's making sure that there's multi-factor authentication, threat monitoring 24/7. It's very, very extensive across a number of technologies that you've approved before, whether it's Microsoft or Proofpoint or Palo Alto or Cisco. It's massive and it's continuous. Next slide. Internally, we have safeguards, we have device management. We can tell if someone is uploading something that doesn't look familiar. If you are an employee and we see that you are going to a site and doing something with certain types of information, we flag that, we stop you, we let your manager know. It's an ongoing effort. Next slide, please. One of the things that shows how well our cybersecurity framework is happening is, as you can see, in the last several years, we have significantly peaked as of 2024 in our cybersecurity framework scoring system that we use with NIST. And I'm very, very proud of the work that this team has done, which basically in 2020, we really were not as protected as we could have been. And the intentionality over the last several years of our information security and networking team, along with others in the organization, because we couldn't do this without the employees, is massive. We have monthly cybersecurity training for every single employee. We have a very high participation rate, even me and Dr. McItis, and we all get nasty grams when we don't do it. And we also have part of our annual training with HR. We also have tests that we take. It is very, very expensive, but most of us know, if you don't know, most of the attacks that you hear about are because someone does something in an email.
I just did mine this morning, Angela.
Yep. Next. Good. All right. All of that being said, with the high-level focus that we had for a short time today, each of my 7 directors and direct reports all have 2 to 3 year strategic plans, which are very, very detailed, have AI strategy, drafts. We have everything that you can think of, and the work that the organization has done has allowed us to be recognized. I know you see some of the things that I've been recognized for here in the Chicago community, but our team has also been recognized, whether it is some of the things that you see on the slide with our collaboration with our Community Health Network, recognition by the American Medical Association, and the reduction of blood pressure from the remote monitoring work that we're doing, to our team being recognized, that Claudia and some of the other people from ACHN in an application that we rolled out that you heard about called Express Care, and some of the other industry standards. I'm very proud of the work that we're allowed to do, and we appreciate you continuing to have confidence in our ability to serve our patients and our end users.
Thank you, Angela. Any questions or comments?
Congratulations on all the work.
Yeah, a lot of work happening.
Mm-hmm.
Yeah, congrats. Yeah,
Thank
really
you.
impressive presentation. Okay, I think we're down to our final presentation. So that'll be the Cook County Health Behavioral Health Services area presented by Dr. Thomas Nutter.
Yes, good morning, directors. Again, Tom Nutter, Chief Behavioral Health Officer for CCH. Thank you for the opportunity to present, and I will be brief on our internal behavioral health services contribution to CCH's overall strategic plan, specifically the establishment of a mental health and substance use disorder service line and the creation of initial action plans from that service line. Where the previous 2 presentations focused on ongoing efforts of established services and their accomplishments, the content that follows is really much more about what our planning processes have been, and I'm very hopeful that the next time we come back, we'll be talking about accomplishments versus planning and process. Next slide, please. So, as you know, you want to go back? Could you go back one? I'll be quick on this one, though. So, as you know, the history of our office is pretty recent, and because of the reality of ARPA funding and wanting to do as much public good as possible and some of the obligation deadlines, we focus mostly on our external kind of improving the behavioral health landscape of the county work in 2024, although there have been some projects within CCH, notably Bronzeville and the CTSC and others, but there have been other internal processes as well. And a lot going on externally, including the countywide strategic plan that finally will be released, I believe, next week. So, and you've seen the details of that previously. Next slide, please. We have an enormously accomplished staff, a very dedicated staff across mental health disciplines and across sites, but not one that has worked as a single unit. Upon our office beginning in, I'd like to say, in fall and early spring 2023, 2024, there was no email list of all behavioral health clinicians. There was no internal meeting of all behavioral health leaders. And so our process has really been to bring together people who are doing outstanding work in their silos into more frequent contact with one another so that we can collaborate more effectively. And again, that's led up to the strategic plan that I'll talk a little bit more about. So the process involves, we've done surveys starting in fall of 2023 and then again repeated at the end of 2024 of all staff working at all sites. We began a clinical leadership meeting just over a year ago of all the leaders of the various areas that meet every other week. I've personally been able to meet with all the, individual leaders, across sites. We had a strategic planning retreat last fall. Thank you to Janine Sergey for leading that effort, and and based on findings, I think we had about 40 participants across disciplines and across sites. Then that information was brought back to those clinical leadership meetings that I mentioned, and over the course of the next several months, 2 action plans were formed, one for carceral settings and the second for non-carceral settings. Next slide, please. Well, there are 2 plans, and I'm not going to review every item of both plans. Both do have the same strategic priorities, and you'll notice that those priorities align well with CCH's strategic pillars and with the Regional Behavioral Health Strategic Plan priority areas, specifically system alignment and collaboration across sites and disciplines, recruitment and workforce development. Seems like that's something we hear about over and over, and we'll likely continue to hear about over and over for some time to come. Access to comprehensive, high-quality behavioral health services, and then 4th, innovation and quality. And so then I'll go over each of those 4. Again, briefly, for alignment and collaboration, the first and foremost thing that we're doing is creating an operations system using existing personnel and utilizing that clinical leadership meeting as kind of the nidus of those efforts at this point. Establishing new org charts for these operation structures, establishing new communication plans, SharePoint site, town hall meetings. The carceral plan will include potential impacts of the 1115 waiver. Second, we'll be establishing processes for assessing programmatic and operational needs. It's striking coming into the system that a number of clinical areas where these processes are developed have very good kind of operational information flowing in, and those efforts really haven't taken place in a systematic way within behavioral health. So there's a lot we can do, particularly in the non-carceral settings that exist a little bit at CIRMAC at present, but there's a lot that we can do and have folks to take point on now at this point. Given the current environment, maximizing revenue opportunities is obviously a major endeavor, and one where I think there, from our study thus far, seems to be significant potential for improvement. One thing I'll highlight here is that we have essentially nearly all of our substance use disorder staff are grant funded, and many of them cannot bill, but we do have a super license through CORE, and so over the next few months we're hoping to be able to expand some of the programming there beyond CORE, so that using that license, some of those staff will be able to bill and potentially then transition to being corporate staff versus being grant funded.
I do have a question.
Yes.
Are primary care providers treating for mental health diagnosis in the primary care setting?
I think they do the basics, right?
Yes, and in certain areas they do a lot more than they would do in other areas. I think they, particularly with pharmacologic treatments of substance use disorders, I think they are much more comfortable than PCPs in other institutions.
Yeah.
I think there's still a lot of areas in which there's obviously a lot of provider to provider variability, and I think when it comes to mental health conditions, there may be a little bit more reticence to prescribe, particularly because we don't have terribly well developed primary care mental health integration at this point.
Yeah.
Because PCPs are a lot more comfortable prescribing if they know that Dr. Smith, Dr. Jones is one phone call away, and we don't have that in place at this point, but in the future at some point.
So there's I haven't looked into it lately, but probably about 8 or 9 years ago, my other job, we adopted the University of Michigan's collaborative care model. So that's a model that really shepherded us into that transition to have physicians see depression or maybe anxiety. And you're right, so everything is pumped up to the psychiatrist. That's at the highest level of their licensure. So I was just curious what the system's perspective was on moving to a model like that, because then you're able to expand the capacities to treatment of mental health, obviously.
From a population, perspective, it just makes tons and tons of sense to do more and more collaborative care. And the system that I come from before being here, in the VA, we had one of the most, probably one of the better primary care mental health integration systems in the country. And so I've seen how it works.
Yeah.
And our community efforts involve a lot of, trying to expand collaborative care. Actually, expansion of collaborative care is one of the metrics within the countywide strategic plan. So you're definitely preaching to the choir on that.
Yep.
And one of the things that's come out of ARPA for us is now at least having some behavioral health staff embedded in all ACHNs. There is a wide gap between having someone in all ACHNs and actually adapting a collaborative care model or similar, one of the other similar models. And that's something that we're certainly working toward. It's certainly something that we're very much convinced is effective. And go ahead, Doc.
Are you saying that the PCPs are not running a basic question with PHQ-9? We're not doing that?
No. They do PHQ-2s. But yes, they do all that. What I'm saying is, in systems like what Director Garza is referring to, what I'm referring to, you've got somebody who, the patient comes in and says, I don't quite feel like myself. Maybe the PHQ-2 screen is positive, maybe it isn't. But then you have a phone call that you can make to an embedded, either via tele or in person, mental health person right there in the clinic, so that it's not here's a phone number to call and then but here's somebody you can talk to now, and those kind of models. We do some of that now, but expansion of those kinds of programs makes a lot of sense.
Yeah, the VA as well as FQHCs have been excellent about having that reliable care, perhaps dovetailing from the health information, now having that decreased documentation, because behavioral health documentation is even more problematic. Having some of that break time will maybe allow for those additional consults that can happen more easily with collaborative care.
Yes, agreed.
It's from experience, it's not an easy transition, because I think when we moved to it, I think we had 7 psychiatrists, like 4 resigned because they didn't want to only see the highest acute patients, they wanted to see everybody. And then I think probably like 5 PCPs resigned because they were like, we didn't go to medical school to be psychiatrists. But those were more mature physicians.
Sure.
So my COO reassured me that coming out of medical school, they're trained to, do more specialty work.
The devil is definitely in the details of how you roll out a program like this. And
well, that was a mistake, Dr. Miller, that we made, because we just dove in and did it.
Yeah.
Had about a year's worth of mistakes, and then we came across the University of Michigan training program, which made a difference for us.
Well,
I don't even know if it's still, I think it's still out there, still regarded. So anyway, thank you.
To your point, psychiatrists are used to managing the patient in front of me, not a panel.
Yeah, right.
And it does take a little while to kind of make that transition. And it's also, there's some challenges for our system, which is in a safety net system, to do a collaborative care kind of model, because the sort of colloquial way people often speak of collaborative care as well, it's sort of like mental health care light for people who don't have the same level of needs. Well, given the level of health-related social needs that some of the folks in our population have, those easy mental health patients with minor depression aren't necessarily, isn't necessarily, the model that University of Washington developed 20 years ago is not necessarily going to be as effective in the settings where we are now. So anyway, that's a tangent probably, but.
Question to Director Rao. Do the FQHCs have a little more capacity in that area?
Oh, yeah. I mean, not all of QHCs have embraced the model fully. I mean, mental health is a service that loses money for FQHCs, because the productivity is much less than a PCP, right? You're only going to be able to see 2 to 2.25 patients an hour, and then The reimbursement's the same for us, but the cost drivers are higher as well. The cost of psychiatrists is higher than a PCP. So yeah, if you fully adopt it, then you create more capacity. Like at our place, if you're a physician and you don't want to see mental health patients, we won't hire you. So it's a requirement of their employment that they have to do it.
And then
So-
having them embedded allows potential, lectures, but that's also not billable. So if the psychiatrist that's embedded in your
Right.
facility gives talks,
That's
helps
true,
to
too.
build up the
That's true.
competence and confidence of primary care prescribers, that's great,
Yeah.
but it's also not a billable cost that we can recoup regardless of
Not
if
for the
it's FQHC or
psychiatrist, no,
for the psychiatrist time. So it does, all of the factors sadly that drive behavioral health reimbursements down, unfortunately perpetuate that lack of collaboration.
But
Well,
if,
go ahead, Director.
but if you have, docs that are going through or either nurse practitioners that are doing their training, could you not use them to ease your load because they're able to do up to a certain level? So I'm talking about tiering here, the ability to be able to have everyone operating at their highest level.
Yeah, we don't have that level, we don't have trainees, in those functions, here,
We
as
don't?
providers, no,
Yeah.
not within mental health.
Huh?
But yes, it's a great use of, yeah.
It's something that they're working on to be able to have fellowships and rotations again.
That may be a
Yeah.
topic for a future strategic plan. It won't be in this one, but yes, I will say that will be, a topic that may come
It
up
sounds
later.
like you're in the ballpark anyway. So you're moving it sounds like you're in the ballpark, you're moving towards it.
Right.
Yeah, that's
Slowly.
good.
Which is
Yeah.
also a good segue into this slide, actually, because as we think about recruitment and workforce development, there are certain themes across really both the carceral settings and non-carceral settings plan. Obviously, improving the recruitment and orientation experience, which has some challenges, but I think those are things that we can, in a lot of cases, improve. There are a lot of opportunities to improve training programs and internal trainings for existing staff, including adding new trainings within LMS. I highlighted a few of the training programs that we think we could pull off in the more short term, but eventually, for Director Robinson's point, there may be other fields to add as well. Next slide, please. Go ahead.
Along with your recovery coordinating position, which is great, I think another pathway that we don't want to exclude is actually peer support. Because those with lived experience, we can route them into peer support positions and then potentially route them up the pipeline for workforce development as well.
100% agree.
Yeah.
And again, we had a very robust peer support in the
Right.
previous system, so I've seen what that's like, so. And then access to comprehensive services, the non-carceral plan includes adding an intake and access clinic at Providence. Using space that's been vacated at the Bronzeville Clinic has opened. Increasing utilization of the CPSC, obviously expanding access to naloxone. The carceral plan includes improving post-release care and communications, particularly for those in the opioid treatment program, and improvement in the RCDC system. There are some opportunities for making that both more efficient and more effective going forward.
And you do have discharge or release naloxone for carceral plan, correct? Are they getting naloxone on release?
It is available. I'm not sure how routinely it's done. And we have the vending machines going in soon. All the officers now have access to have naloxone on their person, so they've made considerable strides over where they were. I'm not sure what the protocols are specifically. I
It'll
can
be
find out more
helpful to
next time
track
I'm over
that because
there.
we know the 30-day outcome and overdose rate for those that are released. So
Sure, and
we
the
wanna make
issue for
sure
those that don't know is that also while you're in a carceral setting, your tolerance for opioids dramatically decreases even over the course of 2 to 3 weeks. And so if you go back and use the same dose that you were using prior to being incarcerated, the results of that use could be, and very often are lethal. So, yes. Yeah. And I can find out more about exactly how we
It'd
do
be
that.
nice to have that as an indicator because I know we're
Yes.
looking and studying that on a larger research vantage point
No,
as well.
That's a good idea. Thank you. And then lastly, innovation and quality, sorry, next slide, Deb. We have a ways to go, but have 2 quality positions coming on board soon, and there's an opportunity to develop new KPIs. One of our metrics will be following the HEDIS measures for follow-up for those who've been admitted to an ED or inpatient setting for substance use disorder, and then obviously more piloting of advanced technologies, including AI, as you heard more about earlier. And then last slide. So next steps, we are establishing exactly what the structure of this operations team will be. Again, it's existing staff that will be utilized. For most of the action items, responsible party, the timelines have been established, but setting those up in a little bit more formal way and what the reporting structures will be has yet to be completed. And then obviously there's much work to be done, but I do want to say thank you in particular to Greg Lee, our Executive Director of Behavioral Health Care Redesign, for taking point on this project. Thank you.
Questions, comments?
I do. For the people who are incarcerated and have found they have some type of substance disorder, what type of treatment are they receiving while they're incarcerated?
Particularly for those with opioid use disorder, the cornerstone of treatment really is making sure that you're on, you're receiving pharmacologic treatment. And we have a longstanding opioid treatment program built within CERMAC. It's still not quite as widely utilized as we'd like it to be, but the team is outstanding. There's been some use of opioid settlement funds to expand that from where it is currently. There are a number of programs that are SUD specific within the jail, some of which are run through CCH, a number of which are run through the Sheriff's Office. There are opportunities for growth in terms of those specifically in psychotherapy for SUD. Particularly on the CCH side, we have some challenges in hiring that are being addressed, and I think we'll be in a better space with about a year or so from now from where we are now. But there's, I think, how we're doing sort of depends on how you. It's either a nationally outstanding program or somewhat inadequate, depending on how you look at it. It is some pieces of it, particularly the OTP, are well developed, and others have a ways to go, particularly to get to where the kind of services that we want to deliver or want for a family member.
But I'll highlight for you, Dr. Nutter, among counties in Illinois, they're ranked as one of the better servers for incarcerated care.
Yes.
For substance use. So we have ways to go, but we also want to laud the work that you're doing.
The reason why I asked the question, because if they have the problem and then they're just going back in, or either they're coming over here, then if we can have a pipeline to put them into continuous help, we might actually solve a lot of problems.
Right. Yes. And it's been an exciting thing to actually be able to have our own OTP within our system now for the last 2 months. It's still a very small program, and it doesn't. The needs at CERMAC are much greater, but at least we have one internal pathway and then lots of pathways with community providers as well, and with the state and MAR system, et cetera. Thank you. Thank you.
Thank you, Dr. Nutter. Well, believe it or not, we're at the end of the agenda. So let me just say this. Really appreciate all the work that went into these presentations, but really it's more about the work that you've mapped out for the upcoming year. I don't know, to me it feels different, this set of presentations. It feels different than what I've experienced in the past. So
They're very intentional.
They're very intentional, they're very focused, they encompass things that we've raised, and very impressive, I would say. So thank you guys for being engaged for the whole period of time, because very comprehensive information that was presented. So thanks again to the staff. Andrea, thank you for pulling it together with your colleagues. The agenda is exhausted. Everyone have a good weekend. The meeting's adjourned. Thank you.